This is an introductory video to the movements in the shoulder region and is part of your directed study on bones, muscles, and vessels of the shoulder and axilla. At this point in the directed study, you should have already done the osteology section. So you've taken out your bone box, you've followed along in the osteology handout, and you've identified the bones and the bone features, and you may or may not have articulated the bones with one another, but we're going to do that here in this introductory video. But the purpose of the video is to really get to that point where you've already identified the bones and we want to know how they articulate and how they move in relation to one another. And that's going to set you up for the remainder of the directed study, which is the muscles, identifying individual muscles, where they're located, and how they act on the bones and move the bones. So in your first year of medical school, you're going to learn a ton of muscles, right? Some students choose to memorize the muscle actions. So they memorize pectoralis major and then it has this action. I don't advocate for that because it's incredibly difficult for most medical students to memorize without understanding how and why. So before we get into the nitty-gritty details of movements at the shoulder joint area, I'm going to give you a sort of background to how muscles work, and I'm hoping that that gives you enough information moving forward to understand why the muscle acts the way it does. In theory, if you understand how the muscle acts, what it's attached to, and what joint it crosses over, you could see a muscle that you've never seen before and intuit its action based on its location. So let me explain what I'm talking about. I'm going to use an example that most people are familiar with. So we know that at the elbow joint, we can flex and extend. So flexion and extension. And the biceps brachii, I use this as my muscle, crosses over the shoulder joint, crosses over the elbow joint, and it attaches down here somewhere on the forearm. We're not really interested in exactly where yet. So you'll see that it crosses over two joints. That means it can act at both joints. So it can cause a motion at the shoulder and it can also cause motion at the elbow. All right, so when we're looking at muscles, it's important to learn the attachment sites. And when we're talking about appendicular muscles in the appendages, there's usually a proximal attachment and a distal attachment. And more often than not, the proximal attachment, where the muscle is attaching up here on my right hand, that part of the muscle is not moving. So in general, if we're talking about just this muscle, so it's stationary at that point. But it's going to exert a tension force on the distal attachment, and that acts to move the bones closer together in this case, so it's moving the forearm closer to the arm, and that flexes the joint, okay? So I'm using that as an example because if you have any sort of muscle, I could put it anywhere else, put it down here, attach the proximal attachment to the forearm and put the distal attachment somewhere down in the digits, it's also going to cause flexion, but now it's doing it at a different location. So do you see what I mean about if you know where the proximal attachment is and the distal attachment, you can intuit that action. So rather than memorizing the individual actions of the muscles, if you know the attachment points and you see where it's located, is it on the anterior side of the upper limb or the posterior side, you can imagine the muscle contracting and sort of get a visual of what's going to happen to the bones. If the distal attachment point is more often than not going to be the part that moves, whatever it's attached to is going to move in the direction of the proximal attachment. Hopefully that makes sense. So moving forward with you looking at your PowerPoint slides with the muscles and the actions, that's why it's so important to know the attachment points. In addition to that, in the PowerPoint and then in atlases and textbooks, you're going to see skeletal images where there's a bunch of red and blue spots all over it. And those are showing you origins and insertions. Now, here at WVSOM, we have been using the proximal and distal attachment terminology rather than calling it origin insertion. There's a reason for that. It's complicated, but sometimes they become opposite. Sometimes they revert, and the origin becomes the insertion becomes the origin. It can be complicated. But basically, when I say proximal attachment, the part that's not moving, that is the referred to as the origin. And whatever the muscle inserts on is referred to as the distal attachment. So anytime you're looking in the book or in the PowerPoint where there is a red area on a bone, so say this area right here is red, that is indicating the origin. So that's showing you that there's some muscle attaching there, and that's the part of the muscle that's not going to move. And then the insertion point will be on another bone in a different location, and that will be a blue part. So if this isn't making sense, look ahead to the PowerPoint. There'll be a little blue area highlighted to indicate that's the insertion point in the muscle. That's where it's going to attach to that bone and act on that bone to move it. Right? Like I said, again, for a muscle to act at a joint, it has to cross over that joint. So again, like the example of the biceps brachii muscle, it's only acting on the elbow and the shoulder because it crosses over those areas. And so there's an attachment proximal and attachment distal. So moving on, I hope that gives you a good idea of how to visualize these things in the PowerPoint and understand exactly where the muscle is. And I want you to, moving forward, imagine it contracting and moving the distal attachment closer to the proximal attachment, and hopefully that'll help you not have to memorize all these things without knowing why. So moving on to something a little bit more specific, let's go over the bones and the joints of the shoulder, and then we'll talk about how they move in relation to each other. So you've already identified the clavicle and the scapula and the humerus in your directed study, but you may or may not have articulated them. So here's the clavicle. Here it's meeting up with the scapula, and I can turn this around and show you. The scapula is on the posterior aspect of the thorax. And of course the humerus, we only focused on the proximal part, but it's attaching to the scapula at that glenoid cavity. So there's a lot of more information than we'll go into today in the joints directed study, but briefly, so that we can understand movements, this is the sternal portion of the clavicle, and it is articulating, it's connected to the sternum. That joint's called the sternoclavicular joint, which makes sense, right? There's actually a lot of movement in that joint, and when we're talking about scapular movements, which I'll explain a little bit later, a lot of that movement is occurring at the sternoclavicular joint. So this is a little bit exaggerated because this middle thing is in the way, and one thing I want to point out right here is that this is the only bony attachment of your entire upper limb to the axial skeleton. Axial skeleton meaning the rib cage, the part that's not limb bones. So the only bony attachment the only thing holding all of this onto the torso is this joint right here. Not the only thing, but the only bony connection. There's tons of ligaments and muscles obviously keeping this stable. But my point in saying that is that gives you such a range of motion here in moving the shoulder joints. And you'll notice that the scapula is not having a bony attachment or a joint with the rib cage. There's muscles behind here, and it's stabilized there, but it is not a joint that is moving when the scapula moves in relation to the rib cage. So that's the sternoclavicular joint. There's the acromial end. I'll flip over to this other side, it'll be a little bit easier. The acromial end of the clavicle attaching to the acromion on the scapula. And that's called the acromioclavicular joint. Little bit less important for movement. There is some movement there, and you'll get more into that later in the year, maybe second year, but that does allow a little bit of movement. The last joint I want to talk about is what people typically refer to as their shoulder joint, but that's confusing because in reality the shoulder is made up of a big complex here, and there's lots of joints involved. But typically when somebody says, oh, I injured my shoulder, they're talking about this joint, and that's the glenohumeral joint. That's the joint between the humeral head and the glenoid cavity. You probably can't see that, but the glenoid cavity on the scapula. And this is a ball and socket joint, and again, this will be reviewed in the joints directed study, but it is a ball and socket joint, so it gives an incredible range of motion, just like the hip. In fact, it's even more range of motion than the hip, but you'll talk about that later. And so there are movements that occur at the glenohumeral joint, and there are movements that occur at the acromioclavicular and the sternoclavicular joints. So those are all different movements, and we're going to go over those in more detail. One thing I do want to point out is that we are being very basic in this video. This is an introduction. As you move along, it's a little bit more complicated than that, and what I mean by that is individual movements that you imagine somebody doing, you know, moving the arm out here or flexing, you know. It does involve multiple movements at once, and we're not going to talk about how that happens altogether. We're going to isolate it and just talk about what joint, the single joint, how it's moving, and what muscles are acting on just that joint. You'll get into more complex motions like circumduction, things like that later. So again, I'm being very simplistic as an introduction. So, before we talk about the specific movements, I want you to think of these movements in two basic groups. We're going to divide it up for simplicity's sake. There are what is referred to as scapular movements, and that was the movements that I was talking about that are mainly occurring at the sternoclavicular joint. All right. So what's happening here is the clavicle and the scapula are moving in some plane in relation to the axial skeleton. So let me show you. All right, and so when this happens, we'll talk about each one of these movements. When this happens, notice that nothing is happening at the glenohumeral joint. This is a big source of confusion. I'm not moving the humerus in relation to the scapula. What is moving is the scapula and the clavicle in relation to the rib cage. Right? That's one set of movements. The second set would then be movements that occur at just the glenohumeral joint. And so, for simplicity's sake, if you just keep the clavicle and the scapula stationary, and you're just moving the upper limb at that joint, you get a whole different series of movements. Now, this is where it's confusing, because obviously, if you just have scapular movements, the upper limb is moving along with it. So the arm, the forearm, the hand, they're all moving along with it. But that's not movement being generated at the glenohumeral joint. That's because the other bones are moving. And that's a source of confusion. So two total separate types of movement. So the first set of movements I want to show you is with the scapula. And the first one is elevation. Elevation involves moving the scapula and clavicle superiorly, as you would if you were shrugging your shoulder. So moving it up superiorly is elevation. When I move it back inferiorly, back to its anatomical position, that is called depression. So those are paired actions. So elevation is shrugging up, and depression is moving inferiorly. Okay? The next set is protraction and retraction. I'm going to move to the side to show this. So protraction involves moving the clavicle and scapula anteriorly. And the best way to describe this is it's sort of the action that you do if you were to punch someone. Now, I don't recommend that you go do this with your classmates to indicate it, but if you punch forward, move your upper limb forward, the scapula will rotate around the rib cage and move anteriorly. I'm having a hard time doing that because there's this thing in the way, but you can get the gist. It moves, rotates around the rib cage and moves anteriorly. That's protraction. Now the opposite movement to that is putting it back in anatomical position. That's called retraction. So again, protraction, moving anteriorly, retraction, moving posteriorly. The last set of movements is downward rotation and upward rotation. So if we move back to the back, looking at the posterior side, when you move the upper limb away from the body, we haven't defined that yet, but we will in a second. When you move it away from the body, it reaches an upper limit. And if you want to continue to move your upper limb sort of closer to your head, what's going to happen is the scapula will rotate upward. Notice how it is tilting so that the clitoid cavity is now up. So that's upward rotation. And the opposite of that is downward rotation. So if you were to put the upper limb back into anatomical position, the scapula ends up rotating downward. So the next set of movements are at the glenohumeral joint, and oftentimes the terminology with this is movement at the shoulder, which is kind of confusing because there's multiple joints in the shoulder region, but what people mean is the glenohumeral joint. So you can hear, flexion extension at the shoulder, abduction adduction at the shoulder, or you might hear flexion extension of the arm, and that's referring to, again, as we talked about in the the overview of the upper limb, it's only this portion of the upper limb, so it's moving the humerus. So that terminology is interchangeable. So the first set of movements we're going to do is flexion and extension. And this is a kind of complicated concept that confuses a lot of students, so I'm going to show you several times. But flexion at the shoulder is similar to flexion at the elbow. So when you flex your elbow, you're moving the forearm close to your arm, right, and decreasing that angle between the two segments. And so it's the same thing and in the same plane at the shoulder. So if you move the arm up, more anteriorly, I guess, and superiorly, that is flexion of the shoulder, and then moving it back into anatomical position, that's extension. Right, so again, flexion at the glenohumeral joint, extension at the glenohumeral joint. Right? Moving on, we're looking at medial and lateral rotation. And as I mentioned in the lecture, this is also referred to as internal and external rotation. Those terms are interchangeable. So I wish I could tell you to just pick the one that makes more sense to you, but you will have clinicians, different clinicians using different terminology, so unfortunately you do need to know both. So medial or internal rotation is when the humerus is rotated forward. Okay, so that's internal rotation. And external rotation is going back to anatomical position, so it's rotating lateral or externally. So again, medial rotation or internal rotation is moving toward the inside of the body. External or lateral rotation is rotating back away from the midline of the body. All right, if we move to the posterior side, we're going to talk about abduction and adduction. The way that I remember this is kind of a little funny. Abduction or abduction, to make sure that I enunciate that correctly, is imagine a little UFO and it's beaming your arm up away from your body. So you're being abducted, abducted. So that's what I imagine. The upper limb moves away from the body because that alien's there beaming it up. Then the opposite of that is adduction, adduction, and that's being added back to your body. So the upper limb gets added back. And again, that's happening at the glenohumeral joint. So AD or abduction, AD, adduction. One additional thing I do want to mention about the two different types of movement in the shoulder region is that those movements will be initiated by a different group of muscles. So going back to our example about origins and insertions and muscle attachments, if we have a muscle that's acting on the scapula and or the clavicle, think about where that muscle would have to attach proximally and where would it have to attach distally to cause movement at those bones. Right? This is the kinds of questions you want to ask yourself moving forward throughout the rest of the year. So think about that for a second. Obviously, the distal attachment is going to be either on the scapula or the clavicle, right? Because that's what it's moving. But the proximal attachment would have to be either on the vertebra, some way. Maybe it's attached to the base of the skull. You see, so that attachment is going to be somewhere along here. And that acts to move just those elements. So that would cause scapular movement. Glenohumeral movement would be somewhere, it could be here, it could be proximal in those same locations we just talked about, and cause the same action. But the difference is that it has to be attached distally on the humerus in some way, or even, this is not possible, but if it were down further, it has to be at least passed onto the humerus, otherwise it cannot move the glenohumeral joint, right? So we can have it attached here, but most of them are attached onto the scapula in some way. So we have a lot of muscles that we're going to cover that are originating on the scapula and inserting somewhere on the proximal part of the humerus. These are rotator cuff muscles and some additional muscles that are not rotator cuff muscles. And so those are the muscles that you're going to be learning that cause movement at the glenohumeral joint.